Hello, everyone. Hello, welcome. Welcome to Beyond the Basics. This is Hallie Cloud. Before we begin, here's just a little intro of our project. Beyond the Basics is a project of the Center on Budget and Policy Priorities. It's designed to provide training and resources to facilitate enrollment in the marketplace and Medicaid. We provide these resources for healthcare assisters, advocates, state and local officials, and others who help people get and keep their health coverage. The Center on Budget and Policy Priorities is a nonprofit policy organization, and it is not a part of the U.S. Department of Health and Human Services. This webinar series is also not intended for press purposes. As always, after the webinar, we're going to circulate the slides. We're also recording today's webinar, and we will post that video to our website, along with any resources that we share today. We're going to post it all at healthreformbeyondthebasics.org. And I'll also put a copy of the slides in the chat as soon as we're done with the intro. Next slide, please. All of you are muted and in listen-only mode. So if you'd like to ask a question, please click on the Q&A icon in the control panel at the bottom of your webinar screen, and then you can type in your question. You can type it in anytime during the presentation. We'll be monitoring throughout, and we'll stop at the end for questions. We're definitely not going to be able to answer every question, but we'll have a record of everything that was asked, and we'll use them as guides for future Q&As and presentations. You are also welcome to email questions to beyondthebasics@cbpp.org, and we can answer it individually. Next slide, please. For today's webinar, which is part 4 in our Open Enrollment 10 series, we're going to cover the ins and outs of how health insurance plans work, as well as an overview of the different types of cost-sharing charges people may encounter and how subsidies on the health insurance marketplace can reduce these costs. We are very excited to have our presenter today, Sarah Lueck, who is the Vice President for Health Policy here at the Center. And I will pass it along to Sarah. And again, welcome everyone.
Hi, thank you, Hallie. Great to have everybody here today. I'm really excited to dig into the details around plan design and hopefully make your OE10 a little bit easier and smoother. So we're going to start by talking about the kind of basic elements or building blocks of qualified health plans, which are the plans in the marketplace. So they have to meet all of the standards and include all the consumer protections that are in the Affordable Care Act. QHPs must also be certified by the Federal Health Insurance Marketplace or by a state-run, state-based marketplace. These plans must include coverage for pre-existing conditions, coverage of the 10 essential health benefits, cost-sharing limits that follow federal rules, and no annual or lifetime benefit limits. And we're going to dig in to the details of benefits and other aspects now. So the essential health benefits are an Affordable Care Act requirement, and they're therefore a basic element of the qualified health plans. You can see here there are 10 general categories of benefits that all these plans must include. So everything from preventive care to hospitalization, maternity care and emergency services, mental health and substance use disorder treatment are all on the list. Another important element of any insurance plan, including the QHPs, is the plan's network. The insurance company that offers the plan will make a contract with physicians, hospitals, and pharmacies to provide services to the people who are enrolled in the plan. And these contracted providers are called the plan's network. They're members of the plan's network. Providers the insurance company doesn't have a contract with are considered out of network. And some insurance plans will cover services if they're provided by an out-of-network provider. But usually if they're covered, the enrollee will still have to pay more out of pocket than if they were going to an in-network provider. And in some cases, a plan won't cover any services that are received from an out-of-network provider, except that they're required to in cases of a medical emergency. It's very important to know that every plan has its own network, And even sometimes the plans that are offered by the same insurance company could have differences in their networks. And that can be important to people that are looking at what plan to choose. And that's another reason why it's important to check into the network and help people to understand their different options. So now we're going to talk about some of the different types of plan networks. So there's these 4 basic types of plans: HMOs, health maintenance organizations; EPOs, exclusive provider organizations; POS plans, point of service plans; and PPOs, preferred provider organizations. First, let's talk about the HMO and POS types of plans. In general, with these types of plans, oops, there's a weird thing going on. Sorry about that. My computer is a little bit out of sync. Hold on one second. It's not showing up. There we go. Okay. Sorry about that. So there's these different types of plans. Let's look at the HMO and the POS first. So the blue and the yellow. You can see that they both have a primary care physician as part of their plan. That's usually required for the enrollee to have a primary care physician. And usually that enrollee is going to have to be working, getting referrals through that, working through the primary care physician to get referrals to other specialists or other providers. And also you can see the networks are smaller for the HMO and the POS plans. That tends to be the case. They tend to have a narrow network, a smaller number of providers that are covered in network in the plan. And then turning to the EPO and the PPOs, the orange and the green, if you can see the colors on your screen, with those, the referrals with the other plans are not required. So people can generally just go to a doctor that's in the plan's network without any kind of referral. They tend to have larger, broader networks than the other plans I was just talking about. And they also, these plans treat out-of-network care a bit differently from each other, right? So the HMO and the EPO do not cover out-of-network care at all. But the POS and the PPO do offer out-of-network care in a lot of cases, but the person who's enrolled in the plan who seeks the out-of-network care is going to have to pay more to get that out-of-network providers services. Next, we're going to talk about the formularies in a qualified health plan. So a formulary is a list of medications an insurance plan will pay for. The formulary splits up covered medications into categories or tiers to indicate the level of coverage the plan provides and the portion of the cost that the enrollee must pay for different medications. The higher the tier of the medication, so tier 4 in this diagram, will be more expensive than tier 1. And generic medications are often on the tier 1 or lower tiers, which means the enrollee can pay the least amount for those medications. Medications that are not listed on a plan's formulary are generally not covered by the plan, though there are some exceptions. Another important element of QHPs are the different kinds of money a person has to pay. So there's 2 broad categories for this. One is premiums, and that's the monthly cost a person pays for their health insurance plan. And the premiums have to be paid every month, kind of like a subscription, or the person's plan may be terminated. Cost sharing charges, on the other hand, are what a person pays when they're enrolled in the plan and they're using the health services that are covered by that plan. So they're paying different types of charges along the way when they're getting healthcare. And I think you may all already know this, but just to point it out, for folks that have low incomes or moderate incomes, there's different types of financial assistance that comes with both of these types of costs in the QHPs that are offered through the marketplace. So many of you have probably already learned about premium tax credits. So that helps people get more affordable access to coverage by reducing the premiums they have to pay. And with cost sharing charges, there's another type of financial assistance that we're going to talk about more later on in the webinar called cost sharing reductions that helps reduce their costs when they get care. So we're going to spend a lot of time on cost sharing charges because it's really important and can be complicated, and there's some terminology involved that's very specific to health insurance. So we're going to just run through these and go through some examples as well, so it's easier to kind of conceptualize how these work. So some of the types of cost sharing charges you may have heard about. The deductible. The deductible is the amount an enrollee must pay out of pocket for healthcare services before their insurance plan generally starts paying for those costs. It resets every year. So if somebody starts in January, their deductible has started. If they come into the marketplace later on in the year, it would start for them at that point when they start. It's an annual cost. And if you go through the entire year in your marketplace plan and then you go into a new QHP, the next year your deductible is going to be reset. It's going to start over again for the following year. Copayments are a set dollar amount that enrollee pays for healthcare services like prescriptions and items and services like prescriptions. So for example, the copayments that you might pay for generic drugs, maybe that'll be $10 per drug or $15 per drug, or you would have a copayment for your physician visit, which is maybe $25. So those are copayments because they're set dollar amounts. And then the third type is coinsurance. So that's when an enrollee pays a percentage of the total cost for healthcare services and prescriptions. So that would be like you have to pay 25% of the cost of a doctor's visit. So it's not a set dollar amount. It can be a bit harder for people to understand because it's a percentage and they don't necessarily know what that's going to mean. But you do see those with hospital bills and doctor visits and other types of benefits or coverage that's part of the QHP. Some more details to know about cost sharing charges. Certain services may be covered before the deductible is met by the enrollee in some plans. This is sometimes called first dollar coverage. And to find out if something is covered before the deductible or apart from the deductible, it may say things in the summary benefits and coverage, a document we're going to talk about in a minute. Might have terms like deductible does not apply to this service or that service is not subject to the deductible. And some plan designs may have a separate deductible for prescription drugs. So one for all medical care, and then a separate one that's usually a lesser amount for prescription drugs. And then preventive care services, because of the Affordable Care Act, are required to be provided without any cost sharing. Certain things that like a well woman visit, screenings for certain types of cancer or chronic diseases, immunizations, and certain FDA-approved contraceptives. Those are on a list, and you can find the list at the link at the bottom of this slide if you want to learn more about this. But for those types of services, because they're preventive care under the definition of the ACA, an enrollee in a QHP will not have to pay a deductible, copayments, or coinsurance for those services. The maximum out-of-pocket limit is another really important feature of QHP. It puts a cap on the amount that an enrollee has to pay in cost sharing charges every year. And this helps protect people from very high out-of-pocket costs when they face a really high-cost illness or they're hospitalized. Like the deductible, this is an amount of money that is set on a yearly basis, so it resets each year. And in the plan design, it applies to in-network services and generally not to out-of-network care. And I'll keep reminding you about that because it can be important. The out-of-pocket limit is not an amount that an enrollee has to spend every year. It's a maximum amount that an enrollee could be asked to spend in a year if they had a very large amount of healthcare costs. Copays, coinsurance, and the amount an enrollee pays towards their deductible all are counted toward this amount. But premium payments are not counted, right? Because premiums are separate from the cost sharing in the plan. After an enrollee reaches the out-of-pocket limit in that year, the insurance plan will then pay for all the remaining in-network healthcare costs, the full amount, with no copays or coinsurance being charged to the enrollee anymore. And some plans will have the maximum out-of-pocket limits allowed, while other will have the maximum amounts allowed, while other plans will have lower out-of-pocket limits. And the chart at the bottom just shows the maximum amounts that are set for the year for 2023 coverage. But again, a lot of folks are going to see smaller numbers, and we'll talk more about that later because of the financial assistance that they're getting. So let's look at an example of how cost sharing works. This is Carl. He is our imaginary enrollee, and we're going to go through a very simple situation that he might face and how that is going to work out under his qualified health plan for the year. And everything I'm about to talk about is in-network kind of example. So setting aside any out-of-network care he might receive, this is all about the protections and the costs that he would face if he was going to in-network healthcare providers. So he's enrolling in a plan in 2022 that has an annual deductible of $3,000, and it has an annual out-of-pocket limit of $7,000. And unfortunately, he has a really large amount of healthcare expenses in this year that we're using. In 2022, he has $40,000 in medical expenses. And we're going to look at how the plan deals with that in his case. So unfortunately, he ends up going to the hospital early in the year, and he is admitted and he has a bunch of things that he needs while he's in there. And the beginning of the year, he's basically required to pay that full amount. The deductible applies to his hospital stay. So he's paying $3,000, which is his deductible, before the insurer is paying anything. So at this stage of the year and of Carl's healthcare that he's receiving, the insurer isn't paying anything. After that point, once Carl has paid that deductible, there's a split where the insurer is paying some and Carl is paying some. In this case, there's copayments and coinsurance that add up to $4,000 for Carl, and the insurer is paying the rest of the cost of services, which in this case is $9,300. So basically, they're sharing that amount once Carl met his deductible. And at that point, Carl has actually, you can see in yellow, he's paid a total of $7,000 for in-network care, and that means he's reached his annual out-of-pocket limit. So additional costs that he has because of his hospital stay and all the care that he gets after he maybe leaves the hospital, that's going to be covered 100% by the insurer. So Carl doesn't pay for that as long as he's going for in-network care. And there's an additional amount of expenses because he's getting a lot of services, and the insurer is going to pay, in this case, more than $23,000. So that's how that works. Now, here's like a specific plan that you can look at and see kind of what it looks like when you're on healthcare.gov. So this is a plan in Miami-Dade County. It's got some of the same parameters that the Carl plan that we just were looking at has. The $3,000 deductible, the $7,000 out-of-pocket maximum. And you can see in this little middle part about copayments and coinsurance, there are several services listed here in this kind of brief summary of the plan that do where the deductible doesn't apply. So in the case of generic drugs and primary doctor and specialist doctor, the deductible does not apply according to this. Those are just copayment amounts that are kind of apart from the deductible. And then you can see that the emergency room care is going to cost first the deductible, because it does apply to that, and then a $500 copay. And to dig in a little bit more deeply on plan details, you would go to this little button that's in the red circle that says plan details. And we'll talk a little bit more about what you'll find there in a moment. But first, let's look into the details of how this would look for Carl if he had this specific plan, and what kind of his cost sharing for different services would be. So with this plan, in this example, he has $34,000 of total medical expenses. You can see in the box by his photo at the top of the page some of the specific types of cost sharing that are in this plan for Carl. So for a hospital stay, he would pay $900 per day after the deductible. He would have a $200 copay for his ambulance. He would have to pay half the cost, or 50% coinsurance, after the deductible for imaging. And then for drugs, he would pay, for example, $20 for generics, but other amounts, higher amounts for brand name drugs and that sort of thing. So to just think about how this works for Carl kind of goes through time, during the year. So initially he does take an ambulance to the hospital, and that costs $1,000 total, as you can see under the little ambulance icon. Carl has to pay a $200 copay for that ambulance. He doesn't have to, in this case, pay his deductible first. That's not what the plan documents indicated. And so the insurer is going to pay the other portion of that. He hasn't met his deductible yet. So then he ends up getting admitted to the hospital, and that's when he does pay his deductible. So he ends up, because the hospital bill is $7,000 total, and again, this is all in network, he is going to pay his $3,000 deductible, and then he's going to stay, in this example, 2 days. So he has $900 a day for a total of $4,800 so far. So in that, at that point, he's, sharing his costs. He's met his deductible. He's paying the after deductible cost of the hospital, and the plan is picking up some of the hospital costs, in this case, $2,200. And then let's say with the hospital visit, he's going to need some imaging and diagnostics done. And for this plan, he's paying 50% of that now. We're in the part of the arrow at the bottom of the page where Carl's paying a bit and the insurer's paying a bit. And because he's met his deductible. So he's paying half of this cost of $3,000 and the insurer is paying half. And then there's a lot of doctor costs. There's some, $20,000 over the course of the year. There's some in the hospital. There's some out of the hospital. But because he's getting so close to his out-of-pocket limit, he's actually only going to end up paying $500 in this example for the doctor visits. And the insurer is going to take care of the rest. And so once he hits his annual out-of-pocket limit of $7,000, he's not paying any more than that. And so in this, we've kind of added the drugs at the end of the sequence, right? He might, in reality, people are getting all of these services at all different times, throughout the year, but we've done a little sequence just to make it a little simpler. And in this sequence, he's hit his out-of-pocket cap, and the drugs that he's needing, the medications that he needs, he's not actually paying for those anymore for that rest of the year. Okay. Now, if it was a family that was on a qualified health plan, there would be some differences in the way the out-of-pocket costs look, those different charges. So generally, the deductible and that maximum out-of-pocket limit for a family of 2 or more people is going to be double what it is for the individual. So if it's $3,000 for an individual, it could be $6,000 for a family. The family deductibles come in 2 different forms, embedded and aggregate. So some plans may have an aggregate deductible, or you could call this a family deductible. It's a little simpler term, where the family would have to meet their entire family deductible before the plan begins to pay the healthcare costs for any of the individual family members. Or you could have another type of plan with an embedded deductible or an individual plus family deductible, where each family member has to meet a smaller deductible amount, and then that's counted towards the larger family deductible. Generally, this is most important to know if there's like 1 or more people within a family who have very, very high medical costs. It might be important to look into the plan documents and see how the deductible accrues. But a really important protection for folks is that any family member, no matter what kind of plan they have, is protected by the individual out-of-pocket maximum that we talked about earlier, $9,100 in 2023, which means that for an unsubsidized person, a person who's not getting any cost sharing reductions, they're going to have that protection no matter what their family deductible is, even if that or what their family out-of-pocket limit might be. Even if their family out-of-pocket limit is much, much higher, no individual person in that family can be asked to pay more than $9,100 for in-network care. All right, so I think just having a simple example of in-network versus out-of-network cost sharing can kind of illustrate why I keep emphasizing this so much and why it's pretty important to try to help people find a plan where they can use in-network care. So at the top of this slide, you can see the different cost sharing amounts for this plan A, a silver plan. The annual deductible for in-network care is $5,000 in this plan, and the annual deductible for out-of-network care is a separate amount. It's $10,000 in this example. And likewise here, you have the annual out-of-pocket limit, which here's the maximum it could be, $9,100 for the year. And then there's no limit on out-of-network spending, which means the person could be, if they're getting out-of-network care, asked to spend unlimited amounts. And then the primary care visit for in-network care is $25 a visit. And then you can see that if you go out-of-network, you'd pay 50% of the coinsurance of allowable charges. And so we're going to do an example that kind of illustrates the difference in costs in a really simplified way. So you can see on the left-hand side that if the person enrolled in this plan goes to an in-network physician and the total doctor's bill is $200, because this is an in-network physician, that physician has agreed to accept the plan's allowed amount. That's the amount that the plan and the physician have essentially agreed that this is going to cost the plan. So this doctor is going to accept the allowed amount of $100, and that benefits the patient because they aren't going to have to pay any more than that allowed amount, and the amount that the patient does pay is based on their copayment. So you can see the allowed amount is $100. The plan gets the plan pays $75, and the patient pays $25, the doctor is getting reimbursed $100. And that amount that the patient pays, that $25, counts toward their in-network out-of-pocket limit for the year, which is the other protection that we were talking about. Now, in contrast, if you have an out-of-network physician and a doctor's bill that's the same amount to begin with, the total is $200, It works very differently if it's out of network. So the plan allowed amount is still $100. And the plan is only going to pay 50% of the cost, right? The patient's asked under the plan to pay that out of network 50% coinsurance, and the plan pays 50. But the total amount that the doctor's charging is 200. And in the case of an out of network doctor, since they don't have a contract with the plan, they can come back to the patient and say, you owe me this other money. The insurer didn't pay me, but you need to pay me because that's, we didn't have an agreement with the insurer. So ultimately, the patient ends up in this example paying far more than because they went out of network. And that's known as balance billing, what I just described, where there's kind of an additional charge in the bill when you use a provider that's not contracted with your insurance. And then also, it doesn't count toward your out-of-pocket limit. So that kind of backstop for really expensive years doesn't exist in this case. All right, actuarial value. I think probably not many, or if any of us on this call are actuaries, which is fine. This is really about demystifying something that's essentially a way to compare generosity of plans and a way to define what cost sharing is in these QHPs. Okay, so don't worry, don't get scared. It's going to be very easy. Actuarial value, or AV, is a way to compare how generous one plan is compared to another. These are this is how the plan metal levels are determined. So the marketplace plans are organized into 4 metal levels: bronze, silver, gold, and platinum. And each of those levels is associated with a different actuarial value. The higher the actuarial value, the less cost sharing that the enrollee must generally pay. And it's basically a way of defining how much this plan provides in coverage to a specific population, a standard population, and then comparing that for each of the metal levels. So it's important to note, AV does not represent what the plan would pay for a particular individual enrolled in the plan. It's, an individual is going to have their own individual experience based on what their costs are, what services they use. But it is a way of kind of comparing plans over a bigger population. It also shouldn't be confused with coinsurance. It can be confusing sometimes because actuarial values are expressed in percentages, and coinsurance is also expressed in a percentage. But if a plan has a 70% AV, that doesn't mean that the plan pays 70 and the enrollee pays 30%. It's totally separate from coinsurance. And then a warning at the bottom, actuarial value is not meant to represent or measure the quality of the plan, the quality of the care provided under the plan, or the size of the plan's network. It's really just a way of kind of looking at comparisons of the cost sharing mainly. So those metal levels that we talked about in general, the higher the metal level, the more precious the metal, the more kind of generous the plan is. Right, so platinum has a 90% of actuarial value, and then the bronze has a 60% actuarial value. The silver plans that are kind of the benchmark for the premium tax credits and that are the basis and the plan that people have to enroll in to get cost sharing reductions has a 70% actuarial value. And then the less kind of generous the plan is, the less precious the metal, the lower the premiums generally are going to be for the consumer that's enrolling in that plan. All right, so let's look at how AV kind of guides what the cost sharing charges are. And the insurers that are offering these plans are basically following certain rules about actuarial value in order to figure out what the deductible under a plan is going to be. If the deductible is that, then what can the out-of-pocket maximum be? And so it's really guiding the design of the cost sharing charges. And here you can see the bronze plan that has a 60% AV. Is in the top left-hand corner of your slide. That is a deductible of $86.50 for the year. And you can see that that's a higher deductible, for example, than the other plans. So if we look at the silver plan, which has a higher actuarial value, there's a $4,500 deductible, so much lower than the one that we had in the bronze example. Similarly, if you go up even further in the metals to the gold plan with an 80% AV, you can see the deductible is even lower. And then the Platinum has the lowest deductible of all. So there's a lot of variation in deductibles when you're looking at plans in different actuarial value levels. There can also be variation in other types of cost sharing charges that we've been talking about. So for example, here you can see, let's just look at the primary doctor visit. In the little boxes at the bottom of each of these little rectangles, you can see the primary doctor visit for the bronze plan is a $100 copayment, while the gold plan requires the enrollee to pay a $25 copayment. So, you know, the people will pay more in premiums for the more generous plans, but they have less in cost sharing charges that are applicable to them. All right, so a lot of what we've been talking about so far is people, our example with Carl and these plans here are all not with cost sharing reductions. These are like the standard plans you would buy if you were not, if you did not have a low income, you did not qualify for cost sharing reductions. But cost sharing reductions are a really important feature in the marketplaces. I think about half of the people that are enrolled in healthcare.gov marketplaces across the country have cost sharing reductions, and probably a lot of the clients that you're helping are going to be eligible for significant assistance. And this is a really important thing to be aware of. So this is a type, cost sharing reductions or CSRs is a type of marketplace subsidy that reduces the out-of-pocket costs an enrollee has to pay for medical care. People who have incomes up to 250% of the poverty line are eligible. And you must enroll in a silver plan through the marketplace in order to access this help. And the way this works is that if you enroll in the silver marketplace plan, and you're eligible for premium tax credits, and the marketplace is figuring out what your income is for purposes of that and what you're eligible for purposes of that, then you're going to, if you're eligible for a CSR and you've enrolled in a silver plan, you're automatically going to get the CSR plan that has the reduced deductible copayments and other things. So there's really nothing else to do then select a silver plan. Then the plan that you get is going to be sort of the version of that silver plan that's for folks at that income level. So you can see in the chart on this slide that a standard silver plan without a CSR has a 70% actuarial value. But then as you go across to the right, you can see that at different income levels, there's a higher actuarial value plan available. So if you go all the way over to the right, a person that has income up to 150% of poverty would be able to get a plan with a 94% actuarial value that comes with a maximum out-of-pocket limit that can be no higher than $3,000 for an individual in 2023. So that's an important protection. And then all of the other kind of charges that we've been talking about today are going to need to be lower in order to meet the standards for those CSR variations. So let's look at how this looks in practice. You can see here that the plan at the top left-hand corner is a 70% AV plan, silver plan, but it doesn't have any CSR, right? There's no cost sharing reduction available there. It has a $5,400 deductible, $6,400 out-of-pocket maximum, and you're paying 10% coinsurance after the deductible to go to the primary care doctor. Now, if I'm somebody who enrolls in that plan and I have a lower income, let's say that I'm going to qualify for the 87% AV plan right below it. And so I have an income, over 150%, but not higher than 200% of poverty line. I'm going to actually enroll in this very same plan. And then the plan that I have is actually going to have a $1,200 deductible instead of a $5,400 deductible, a $2,200 out-of-pocket maximum instead of the $6,400 in the unsubsidized plan. And I'm going to have the same actual cost sharing for the primary care doctor, the 10% after the deductible. And so you can see here it's good. The red boxes also show, what my premium would be because I'm getting a subsidy for the premium tax credit as well. So this is just really a way to make sure that folks who are, at lower income levels are able to access healthcare at more affordable amounts. Okay, so let's look a little bit more closely at how this would work. The example we did for Carl before had a non-subsidized plan, and this has a subsidized plan with a very similar kind of set of costs. So you can see at the top, the little box by the long rectangle by his photo, that his plan here is going to have reduced cost sharing. I think this happens to be an 87% AV plan. His ambulance is going to be a $200 copay. His hospital is going to have a $500 copay. The deductible does not apply in those cases. $200 copay, doctors, no charge in the hospital. And then drugs here, the example is $15 generics. So go all the way down to the bottom and look at the arrow. And for this plan design, he's actually going to have no deductible at all for anything that's in network. And then some various cost sharing co-payments that go along the way, and then an out-of-pocket limit of $2,500. So significantly lower costs, right? No deductible is a pretty big deal to make coverage more affordable for folks. So what happens during the year when he has his ambulance ride, he's asked to pay the $200 copay. When he goes to the hospital, he's being charged $500, which is much less than I think it was $4,800 in our other example, much less for the hospital stay. He's paying a $200 copayment for imaging. He's paying $160 toward the doctor visits. In this case, they're not all in the hospital. So he's not charged for the doctor visits in the hospital under the plan design here, but maybe he had some visits when he got out with some doctors that required a copayment. It actually turns out that, I guess because the co-payments are relatively low compared to the out-of-pocket limit in this example, the money that Carl's paying out of pocket in this very difficult year with very high costs, it reaches around $1,100 for the year, and it never actually hits his out-of-pocket limit, which is under his reduced cost plan, $2,500 for the year. So unsubsidized, he was paying $7,000 for essentially the same set of events, and in this case, $1,100. And then I wanted to show an example of two plans that are within the same CSR level. So two 87% AV plans with the reduced cost sharing that I was just talking about. I think it just goes to show why it's important to compare plans, even when someone's qualifying for cost sharing reductions. You might think, oh, it can't be that different, but it really can be. Even with AVs that are higher, it can be quite different in terms of the way the costs are structured and what the person might experience depending upon the health services that they use. So in this case, you can see these are two plans, that have about the same monthly premium, and their deductibles are very different. So these are 87% AV plans, but the top one has a $2,100 deductible, and the bottom one has a $200 deductible. So that's quite different. And then you can see there's different kind of charges for different parameters here. $2,100 out-of-pocket maximum for the top one and $2,900 for the lower one. But basically, the top plan the one on the top is gonna have a lot higher upfront costs for somebody that uses, pretty much anything other than preventive care. It looks like you can get your primary doctor visit with no charge. You can get your generic drugs for no charge, but somebody who ended up in the hospital ostensibly would have a pretty high upfront cost for that. We wanted to mention that there are special rules around cost sharing for American Indians and Alaskan Natives, or AIAN folks. So this is also part of the ACA. People who are members of federally recognized Native American tribes and Alaska Native Claims Settlement Act corporation shareholders can enroll in or change marketplace plans each month without having to qualify for a special enrollment period. And in terms of cost sharing help or help financial assistance, between 100% of the poverty line and 300% of the poverty line, folks who qualify for PTC can also get zero cost sharing plans. And in these plans, enrollees pay no deductibles, co-payments, or other cost sharing when using in-network covered healthcare services. Some network out-of-network care is also available with zero cost sharing for this group. And then for people who have incomes, for AIAN, people who have incomes below the poverty line or above 300% of the poverty line, there is a limited cost sharing plan available in which the enrollee pays no cost sharing charges if they receive services from an Indian health services provider or from another provider that they've been referred to from an IHS provider. All right, plan design resources. So this is just some tips and some information about different ways you can kind of, after you're off of this webinar and maybe even really helping folks, how you can kind of figure out some of the details that you might need to know. So earlier I mentioned the SBC, that's the Summary of Benefits and Coverage. And that's a document that most health insurance plans are required to provide to people as a result of the Affordable Care Act. I get one from my employer coverage, and you can probably get yours too if you want to get familiar with it. But they're also posted online, and in the healthcare.gov website, you can get to these plan documents. You can see on the, when you're searching for plans, you can see on the left over here, there's this column with AvMed and Trust Silver 300. In this space, you can see at the bottom, it says plan documents and summary of benefits. That's where you'll find this form. Once you kind of click on a plan in healthcare.gov and ask for plan details, you can get into documents and find the SBC or the summary of benefits. It is a standardized form, so there's a certain way that it looks all of the time and certain things that insurers have to provide in certain places. So once you get familiar with this as a tool, it can be really, really helpful as a way to quickly identify maybe the answer to a client's question, or to compare the cost sharing or the coverage that's available for something from one plan to the next. These are also available for cost sharing reduction versions of every silver plan. So you should be able to find everything you need to help people understand how their costs are reduced if they enroll in a silver plan. So here you can see just a couple of examples of what you might find on an SBC. So in this case, these are standard questions that you see. Are there services covered before you meet your deductible? Yes, preventive care, as we talked about, but then also in this plan, certain prescription drugs, office visits, ambulance and urgent care, a bunch of different services that are covered before you meet your deductible, which is good information to know. And then you'll see further into the SBC, it's several pages long. You can kind of scroll down or turn pages until you get to these scenarios. If you have on the right-hand side with these blue squares, if you visit a healthcare provider's office, here's what will happen. Specialist visits are $80 copay per visit. If you have a test, a diagnostic test is $100 copay per visit at independent facilities, for example, and emergency room care is $500 copay after your deductible. And these SBCs should be telling you if it's after the deductible, if the deductible doesn't apply. Those kinds of details should all be available. Another useful tool is this form that Beyond the Basics created. It's just a plan comparison worksheet that you can kind of compare these 4 plans side by side. You can fill it out on your computer and print it or email it to your client. And it's available in a number of languages that you can see listed here. So it's just another way of pulling together all of the information that you may be helping people find either on the healthcare.gov website or details of the SBC that people are particularly interested in knowing so that they can try to make the decision that they need to make. And then new for 2023, marketplace insurers are going to be required to offer certain standardized plans, meaning that the plans have standardized cost sharing amounts. And this is a new thing that's, I think, could be very helpful to folks. The plans are required for every network type and at every metal level for which an insurer is offering a QHP in a given service area. So for example, if an insurer offers a gold HMO plan in a service area, which is, maybe your town, then it must also offer a gold HMO standardized plan throughout that area. So you'll always have sort of a standardized version that you could look at. This doesn't apply in the state-based marketplaces, and it doesn't apply in Delaware, Louisiana, or Oregon, where I believe there are special rules or standardization already in place. And it can help aid plan comparison. So just to take a look at the chart at the bottom of this page, you can see that there's a bronze. These are the different variations, the standardized plans that have been created that insurers have to provide. So they will have a bronze plan with a $9,100 deductible, an expanded bronze plan that has like a higher actuarial value, you can see there, and has a lower deductible. a standard silver, and then the CSR variations, a gold and a platinum. So for the folks that are getting cost sharing reductions, there are going to be standardized plans for them. They're supposed to be labeled in healthcare.gov. I don't know yet what exactly the labeling will be, but you should be able to see them with an icon or some sort of labeling when they're there. They have been optional in the past, so they've been around a bit, but these are based on really popular cost sharing designs that have already existed in the marketplace. And it could be a really useful way of seeing like comparing the premiums for two plans that have the same cost sharing, right? So it could be just a way of learning a little bit more about plans. I think a downside of it is there's probably going to be a lot more plans. So it will just be very handy to use the website and the filtering tools and to try to zero in on what a client is really looking for, because there could be a lot more plans, at least for now. And then I'll just mention very briefly, there are plans out there in the market that are not qualified health plans. They don't meet the standards of the Affordable Care Act. They don't have all those protections or benefits that I was talking about during this presentation. They're not certified by a marketplace, and they have a lot of problems and a lot of lack of consumer protections. But they're out there. People are getting phone calls and emails pushing them to enroll in these kinds of plans. So it's just something to be on the lookout for. In the yellow column on the left, you can see a couple of types of plans that may kind of fit this bill. Short-term limited duration plans are one example. Association health plans can potentially be another example. Healthcare sharing ministries and indemnity plans. So just, I think you recognize these in the wild if they're asking people questions about, their weight or their pre-existing health conditions, because the plans will look at those details of a person, which is not allowed in the ACA marketplace, to try to decide how much they will pay for their coverage, or whether that person will be offered coverage. They may deny coverage based on those pre-existing conditions. They might impose limits on how much they'll pay out for those conditions, which also isn't allowed in QHPs. They don't have certain essential health benefits, and they may limit what they pay out. So they expose people to high costs, and they're not that cheap in a lot of cases. They have somewhat lower premiums in some cases, but especially with tax credits and with the cost sharing reductions, there's a lot of assistance for folks out there right now. So it's just a much better value and a better deal to try to get the coverage that's really going to protect you if something happens. I'm not going to actually go into great detail on all of the features of short-term plans. You can find them in your slides, but in a lot of states, not all states, some have banned these plans or limited them to very short periods of time, but some of them are basically called short-term plans, but they end up covering people for way longer. So they're nominally short-term plans. They're not necessarily lasting a full year. But then that's kind of keeping them outside the normal ACA rules and the normal market and all of the protections that I was just talking about. They often don't cover maternity. I've never seen a short-term plan that covers maternity care. They often don't cover prescription drugs. They often don't cover mental health benefits and substance use disorder treatment. And they have a lot of those limitations that we were just talking about. The tricky thing is, if you see one on the internet, it may look very much like a comprehensive health plan. It could have a premium, it'll have a deductible, it'll talk about having a provider network, but it is not the same at all, and it's important to be aware that those are out there. Direct enrollment is something that is allowed. The federal marketplace allows this practice. Direct enrollment is called DE, and enhanced direct enrollment is called EDE. This is when insurers and brokers, including online web brokers, use their own websites rather than healthcare.gov to let people apply for and enroll in marketplace plans and receive subsidies. So with direct enrollment websites, those will send the consumer to healthcare.gov for an eligibility determination, and then back to the direct enrollment site, the insurer site or the broker site, to select a plan. With enhanced direct enrollment, that can allow an insurer or a broker to keep a consumer at its own website for the entire process without sending them to healthcare.gov. Some DE and EDE sites do sell short-term and other skimpy plans. They're not allowed to display these plans alongside QHPs, so there's a recognition that those are not as good. But in some cases, it can be confusing for people that are on these sites. Individuals may get sort of heavily promoted to look at these other kinds of plans, even if they're not getting marketed right alongside the QHP. And there have been some instances where direct enrollment and enhanced direct enrollment websites try to sell skimpy plans to people who actually are eligible for Medicaid instead of helping direct them to the right resources and get them to Medicaid. So that's super unfortunate and a good reason why working through the marketplace can be really advantageous. So what could you do to help with this situation? Promoting open enrollment in healthcare.gov is job one, or your state marketplace if you're in a state that runs its own. Understanding the risks of these kind of skimpy plans, like short-term plans, and informing people about that. If it can be important sometimes to help people see past just the low premium that might be there and understand the high cost they could face if they enrolled in that plan and then got sick, and to help understand, I think, also the value of the coverage in the marketplace and the good assistance that people can often get if they have lower incomes. A lot of times short-term plans or other kinds of skimpy plans are promoted as a way to help people bridge gaps between other types of coverage if they're like short periods of coverage. But in reality, you can use the marketplace plans for that purpose. There are special enrollment periods that folks can access, as we talked about in other webinars. And you can help people get coverage as well as financial assistance through the marketplaces, even if it's only for a short period of time before their job coverage starts or whatever it might be. It can be really helpful for those of you who are on the front lines helping consumers to track and report what's happening on the ground. If you're seeing misleading or fraudulent marketing, that's helpful to report. You can inform your insurance regulator in your state about fraud or misinformation that you see that people are getting, and you can let people know that they have a right to complain to an insurance regulator about the things that they're seeing. It's helpful to monitor accuracy of information that consumers are getting and track the experiences of consumers who do enroll in these plans, which, from the news stories and accounts of some of the folks that have, had coverage denied and claims denied, it can be very expensive and difficult to deal with, a serious illness and having this type of the skimpier coverage. And with that, Hallie, I'm ready to go to Q&A.
Yeah, we have lots of good questions. And again, we're not going to be able to get to all of the questions, but we do have a record of them. And you're also welcome to email us directly at beyondthebasics@cbpp.org. And we can answer questions individually over email that way. So one very quick question on those skimpy plans. How will people know that they are skimpy plans? Are they going to see these in the marketplaces, or is this really something to look out for outside of the marketplace?
If you're on the healthcare.gov website, or if you're on the website for your state-based marketplace, these are not plans that you're going to see there. They're not certified by the marketplaces, so they're not going to be getting marketed on those marketplace sites. So, the tricky thing is that sometimes people Google a term and then end up at a different type of website. But if you're helping people and they know to go to healthcare.gov, for example, or to the official website of the public marketplace in your state, then they will be getting qualified health plan information.
Perfect, thank you. And then we had a question about copays and whether they count towards the deductible. So this is kind of going back to the beginning of the presentation, but with our example for Carl, he had a $200 deductible, or copay for an ambulance ride. So would that count towards his deductible?
No, generally no, copays don't count toward the deductible. You can find the details in the plan documents about after deductible, before deductible, but usually the copayment is separate from the deductible itself. So a lot of the examples that we were just running through, he, with his ambulance copay, for example, Hallie, that you mentioned, that was separate from the deductible. So he had the $3,000 deductible, but he had the ambulance ride and he wasn't charged the $3,000, right? He was just charged the $200 copay. So that's separate from the deductible. And a lot of times when something's separate from the deductible, there's a copayment that you're being asked to pay. So that's the case sometimes with prescription drugs. The deductible doesn't apply, but there's a copayment.
And just to tie the loop on that, do those copays count towards the out-of-pocket limit?
They do, yeah. So any, even if a copay doesn't count toward the deductible, it's part of the total spending that the person has for that year. So any charges under the plan that are in network and covered are going to count toward that maximum out-of-pocket limit.
Awesome. And then can someone have like a copayment and coinsurance where they pay a percentage of a charge together in one plan, or is a plan going to have one or the other?
That's a really good question. No, different services could have different types of cost sharing. I think a lot of times the more generous plans have more copayments, but I think you'll often see a mix of copayments and coinsurance, particularly in like a bronze plan. So I think you'll see both depending upon the service. And I think the doctor visit, the prescriptions are often copayments. But if you look at the drug cost sharing in a given plan, you might see that like the higher tiers that we talked about that are more expensive drugs, like specialty drugs, that'll be like the highest tier and it will have a coinsurance often. So maybe like 40% coinsurance for specialty drugs, while the preferred brand drugs are like $25 copayment and the generic drugs are $15 copayment. So you will see even within a drug formulary, a mix of coinsurance and copayment.
Thank you. And then with a summary of benefits and coverage, are you going to see a difference for between summary of benefit and coverages for different plans that are within the same insurance provider? So let's say that Ambetter has a balanced care 31 and a balanced care 32. Are those SBCs going to be the same for both of those plans, or are there going to be variations within different plans under the same insurer?
Right. So each plan has to have its own SBC. And so there will be differences, even though they might be small, between two different plans that are even offered by the same insurer. So you should either, on the healthcare.gov website, if you're looking at the plan documents, each plan will have its own set of documents. And within each of those plans, you'll find its own SBC. And if you print them out and put them side by side, you'll see some differences, even though they're from the same insurer, and they might not be very, very, very big differences in some cases.
Then we're gonna do a couple more questions. For when someone gets an eligibility determination through healthcare.gov, is that notice going to show if someone is eligible for cost sharing reductions? Is it going to show the cost sharing reduction amount someone qualifies for on that eligibility notice?
Good question. Yeah, it will show that the person is eligible for cost sharing, and there's a line in the notice that says this person's eligible for cost sharing assistance to reduce their cost sharing charges, their deductibles and copayments. It says something like that. And then it also says you should enroll in a silver plan in order to get cost sharing assistance. So those are codes that you will know that that's a person who's eligible for cost sharing reductions. There isn't a place on the form that I'm aware of that straight out tells you in the eligibility notice, this is the cost sharing reduction plan that this level is what you're eligible for. Like you're eligible for the 87% or you're eligible for the 94% AV plan. It doesn't have that, but it does tell you at the top, near the top, that what the income is that they found you eligible for PTCs at, for premium tax credits. So you know what income has been part of the eligibility application. And if you do a little more legwork, you can just match that up with which CSR level is that person going to be, to give them a little bit more information about what the plan might look like. But of course, when they're in the website and they're doing the application and they go from the application into plan selection, and after they've been found eligible, they will automatically be shown the silver plans that they're eligible for.
And then last question, which ties into that question quite well, but can a person use cost sharing reductions with a gold plan, or do they have to enroll in a silver plan?
You will not get cost sharing reductions with a gold plan. You will only get them with a silver plan. And generally for people who are eligible for cost sharing reductions, they're going to be better off in the silver plan, even though, the gold plans are more generous at the base, just without any extra help, they have lower deductibles generally, but the cost sharing reductions, basically with the 87% AV or a 94% AV, you're above the gold AV already. So those are going to be more generous plans for folks that are eligible for that level of cost sharing reduction.
Awesome. And I think that that kind of brings us to the top of the hour. So we're going to bring this to a close. If you go to the next slide, I think we have a whole list of resources. I know that you can't click on any of the links in the Zoom toolbar, or in the Zoom right now, but the link to the slides is in the chat right now. We'll also send out the slides after the presentation. We'll probably send them next week, as well as a video recording of this webinar. And we'll have all of those resources listed on the website as well. Also next week, our next webinar is next Thursday, and that's going to go over really detailed plan selection strategies. So that's a really good companion for with this webinar. So that will be next week on Thursday, same time. So you can register for that at our website on the upcoming webinars page. And then as you can see, we also have a bunch of other upcoming webinars, including one in Spanish. It's entirely in Spanish, and it's going to be about how to assist people. And we're really excited about that one. That one will be on Thursday, October 20th. So again, thank you so much for coming today. We'll distribute everything after the webinar next week. We'll send an email to everyone. You can also just go straight to our website at Beyond the Basics, at Health Reform beyondthebasics.org. We post everything there. If your question didn't get answered, if you have another question, please email us at beyondthebasics@cbpp.org. And we just really appreciate you guys taking the time to come today. And we hope you will join us for our future webinars. And with that, I think we will bring this to a close. So thank you so much, everyone.
Thanks, everybody.